Hi everybody, thank you for watching. So our project is on pneumonia classification and localization with deep learning. I'm Johnny and my partner is Ian. So a little background information. Coronavirus disease 2019, or also known as COVID-19, is an infectious disease that was kind of discovered sort of sometimes around the late 2019. So its primary mode of transmission is that it spreads through droplets of saliva or discharge when an infected person coughs or sneezes. And just because of how viral it is in nature, this caused a global pandemic leading to an economic lockdown, which we're currently in one right now. So, for the majority of people, they usually experience mild flu like symptoms like coughing or fevers. However, more severe cases can lead to pneumonia, which led to a recent spike in hospitalization and mortality. So, on the right, you'll see a chart that plots the daily death worldwide since the beginning of this year. So, what is pneumonia? Pneumonia is a lung infection that causes the air sacs to become inflamed, and this can happen in either one or both lungs. So, some side effects: coughing, phlegm or pus production, fever, chills, difficulty breathing, and death. So, the problem statement is that diagnosing pneumonia continues to be a challenge, and this is because it typically requires a trained physician that has clinical judgment to accurately identify pneumonia. So this can be a slow and expensive procedure, especially if it requires medical tests like blood tests, x-rays, bronchoscopy, CT scans. So fundamentally, speed and cost can impact a patient's survival rate. So our objective is to develop a neural network that can analyze chest x-rays, identify if pneumonia is present, and then determine the severity of pneumonia. Why is this important? Because a cheap, efficient, fast, and reliable machine learning model that can accurately and precisely identify pneumonia can help free up hospital personnel and resources. And this would allow doctors to efficiently apply treatment as soon as they're informed. And this is ultimately aims to increase patient survival rates.
Hi, my name's Ian Burnside. So here are some of the chest x-ray images from our data set. Half are normal and the other half have pneumonia. Take a moment to try and guess which ones are which. Starting out, I had them all separate into their folders, and I'd look through them and say, yeah, I could totally see that this one's pneumonia, or this one's pneumonia, or this one's like normal. But I mean, like I really had no idea, and I was just saying that because it was in that folder that was labeled pneumonia or normal. So um, when I mixed them up like this, I really understood how subtle the signs are and realized that the connections that my brain was making were not really good ones. So here are the labeled images. You can see how well you did in guessing. But because I was so bad when it was mixed up like this, it really made me appreciate how difficult the task is that we have for our neural network. Two papers were the inspiration for our project. The first one was able to classify different types of lung infections with 99% accuracy, and it had a custom neural network. The second one had a 98% accuracy and then used existing neural networks like Resonate 18 and DenseNet. It also incorporated these activation maps here, which highlight the areas of the image that led to the final determination. It sort of highlights the localized area in the image where the pneumonia is located, the infection is located. For our approach, we chose to use a CNN as well. We wanted to do a custom architecture, so no pre-existing architecture was used. We really wanted to understand this process from the ground up, essentially, um, and uh, and uh, and tailor it specifically to our data set. Um, all of this was done with the Keras API and Google Colab to make collaboration easier. And the model contains these functions you see here, and we arrange these functions into layers in the iterative process to see which arrangements, variables, and hyperparameters were better. We did around 80 to 100 iterations, and they usually took around 25 minutes each. If the data was already loaded into the RAM for Colab, it would take 50 minutes if it had to be entered in cold. And we'd cancel runs prematurely if it was showing bad validation accuracy on the graph, just so we could save some time. But looking back, there wasn't really a solid correlation we saw between validation accuracy and test accuracy performance, oddly enough. So we might have missed some good runs by doing that. The data set is from Kaggle.com, and you can find it by looking up this phrase here: chest X-ray images pneumonia. There are about 6,000 images in this set, broken up by classes and folders. There are only 16 images in the training set, so we took some of the training set images and put them in the validation set to increase the resolution of our validation accuracy tests. It's pretty interesting how this data set was validated. So first, 2 expert physicians ensured the accuracy of the diagnosis, and they kind of like agreed on it, I guess, and maybe threw out the ones they couldn't agree on. And a 3rd expert independently verified their grading, essentially, to make sure that essentially make sure the highest accuracy possible for this data set. So for the convolutional layers, we use the conv2D function in our convolutional layers, and we varied the filter size, the order, the number of layers in our runs, but we kept the kernel at about or at 3 by 3. And below is sort of a list of how we went through the process here through trial and error of starting with like 3 layers and decreasing filter size, seeing what the accuracy was, 5 layers, decreasing filter size, etc. Ended up settling on 3 layers of increasing filter size of a high validation accuracy of 90%. So we used max pooling to emphasize the specific features of the model and an improved accuracy. But looking back, the subtleness of what we're classifying makes me think that average pooling might have been a good thing to try. But we didn't try it because everyone said that it was not nearly as useful as max pool. But it would be something that I would probably want to revisit again and do a run or 2 in the future. We did a lot of experimenting with dropouts, and we learned in the lab that typical dropouts are from 0.2 to 0.4, and sometimes you can go high as 0.5, but we were experiencing some extreme overfitting, so we wanted to see what higher values of dropout would do, might as well. So we did a few runs with 0.6 and 0.8 extreme values, and yeah, we should have known it had terrible accuracy. But it's mostly because we were shutting out 60 to 80% of the neurons, and the model just didn't train properly in the first place, so we had to find another way to reduce overfitting. We did a lot of experiments, and ultimately 0.4 seemed to be the best for our model. And then for the batch runs, we used a batch size of 8 and 20 epochs typically. Overall, let's see. I think we had a really good data set overall. We did do some pre-processing and sized the images to 200 by 200 and made sure they were all grayscaled and normalized. The data set had no blurry images. All those were removed, and they were all oriented correctly. Some disadvantages are that the aspect ratio varied significantly and some were not cropped well. So some images might stretch a bit when sized to 200 pixels. There were some artifacts like writing on some of the images and medical devices that you can see over here but these are kind of unavoidable in a realistic setting, you know. So and although it doesn't seem like a drawback, they were pretty quite high quality images, and it did cause extra processing in Google Colab. Looking back, we probably could have resized the data set to help improve the Colab performance and processing time. And like I mentioned, overfitting was a significant issue, and there were significant false positives, meaning the network was seeing indicators of pneumonia that were not actually indicators of pneumonia. Uh, and we tried normalization through dropout with values ranging from zero point 0.2 to zero point 0.8, as I mentioned earlier. And I'd say we spent probably most of our runs trying to fix this overfitting, but ultimately we couldn't resolve the overfitting issue.
So for our results, we have very high train and validation accuracy, 99 and 96% respectively. However, we were only able to get a test accuracy of 78 or 79%. And so this high train and validation accuracy but low test accuracy indicates to us that the model is overfitted. Something to note is that in the graph on the right, you see our validation loss and validation accuracy is really volatile. And this could be because of our unbalanced data set. We have thousands of trained images and only 50 validation images. Here you see our confusion matrix, which we evaluated against our test images. You can see that we have a very high number of true positives, or our model was able to correctly identify pneumonia cases correctly. However, we were only able to get 61% precision score and 80% recall score. So this is typically low accuracy, and so we recommend adjusting the threshold to target 100% recall. This would ensure that all patients with pneumonia will be correctly identified and they could receive the extra medical attention they require. So, to summarize, our objective was to design this machine learning model to identify pneumonia and quantify the severity. We had very high train and very high validation accuracy, but lower test accuracy, indicating that the model could be overfitting. This would require tweaking some of the hyperparameters or increasing dropout. We could also try data augmentation to increase the quantity in our data set. So this could be done by rotating or flipping some of the images. For activation maps, we were unsuccessful due to the computational limit of Google Colab because we exceeded the RAM. So we may want to try using HPC or Google Colab Pro. And if anyone's interested, here's a list of our references